That way. All set? Okay. This is what happens when when surgeons try to handle all the tech. Dr. Crapp and I have been speaking for a few minutes, and just we were told that we actually weren't live, so we are gonna. Dr. Crapp has to get to hear his whole life history all over again. So thank you for those who were patient enough. Dr. Seth Crapp is joining us here. As you see, he's a board certified radiologist. He has a CAQ, Certificate of Added Qualification in Pediatric Radiology. He is a Miami boy, having done his undergraduate work in chemistry at Florida International University, so FIU. He went to medical school in Tennessee at Meharry, and then did his internal medicine internship at a Harvard-affiliated hospital, followed by radiology at a Shands Hospital. So University of Florida. He is a Gator, right? Right. And in Miami, there's a lot of his talk. Then he did pediatric radiology at Vanderbilt. So that's another subspecialty. So this, people are getting an idea of the long journey, and which I talk about in section 1 of my book. That so the public understands the journey that all of us go through to be able to take care of all of you. And then the struggles that we have to actually get fairly compensated for our work. And this is, we're coming to a crisis here. He happens to be a fellow frat guy, fraternity brother from another house. He's an entrepreneur, particularly in teleradiology, which we started to speak about. And he's also an executive in Leading Edge Surgery Center, which is an outpatient surgery center network that may, in fact, very soon collaborate with our ortho-now model, so that patients really have a seamless way to receive musculoskeletal care, of which teleradiology is critical. I use it every day on my app. So welcome, Dr. Crapp. So happy to have you here.
Thank you so much, Alejandro. It's great to see you. Thank you. So
tell us about your journey in getting to teleradiology, briefly, in terms of you after your residency, but what brought you to the entrepreneurial stage?
Absolutely. So, teleradiology has always been a part of my practice. In fact, I had been doing it since 2011 when I was in fellowship. I used to moonlight doing teleradiology for certain entities and clinics in Florida. So my first position was with a company called Sheridan Radiology, which is a small but now large practice that was based in Florida, but now it's a national company called Envision. Subsequent to that, I ended up joining a smaller practice and then a larger practice in Tampa. But all during that time, we used some form of teleradiology, and most radiologists had workstations at their homes. So I was very familiar with how teleradiology worked.
You guys were ahead of your time, I should say. Much like dentists are in terms of orthopedic bony work, I want to point out the radiologists have been doing this remote technology, and now we're using it to really care for patients to some degree, basically because of the pandemic. The engagement. So okay, so then you kind of went on your own, correct? Almost.
Correct. So in 2020, height of COVID, most radiologists had begun incorporating some form of teleradiology, and in fact, it became the predominant way to do work because of the risk of COVID and a lot of the shutdowns and so on and so forth. So knowing this, I think the opportunity sort of presented itself, and I saw the opportunity to go out and forge a path of my own and see if I could take advantage of the disruption, because everyone had moved to teleradiology. So that was August 2020. I began South Florida Radiology.
Okay, and then you recently focused on a company on pediatric teleradiology, which I wanted you to give a clinical example. Like a patient comes in, what are more common things, and walk us through what a mom would be dealing with when she goes in somewhere, and how your company would help them.
Okay, so definitely I can do that. One of the most common things that we see as pediatric radiologists is you have a small child, baby, or pediatrics 18 and under, come in with a cough. And the pediatrician or the emergency room doctor, they want to know, is there pneumonia or is this just some type of viral or asthma or something, or bronchitis? That is one of the number one things we see most indications. So we would actually have the film sent to us remotely, wherever we're located, and then review that film and then relay the report back to the clinician. And the key differentiator is the path of treatment would be, if there is a pneumonia, they're going to go down a certain path of antibiotics. And if it's severe, they may be hospitalized. And if it's not, then they're going to be treated as an outpatient. So that's one of the very critical decision pathways that we have to help out with when we're doing pediatric radiology.
So this is very critical. The public needs to understand. I mean, you have this incredible breadth of knowledge, which the treating clinician, has to a certain degree, but they don't have subspecialty training, particularly in looking at pediatric chest film, right? I mean, I would be completely lost there. And I was an ER doc also to make some money, but I can tell you that we didn't see kids at the VA, thank God. And the kids come in with a chest film, and to be able to determine, right, if there is a subtle pneumonia there is a real skill, and that's gonna influence the care in a major way, correct?
Absolutely. Now I'll give you one more because you're an orthopedic surgeon. Another one, I would say number one, number two. Kid comes in, they have a fall. They want to know, look, is there a fracture or not? Again, decision tree pathway. If there is a fracture, they're going to see you or one of your colleagues. If there isn't, or they may be hospitalized or get sent to the ER if it's an outpatient setting. If there's no fracture, conservative treatment, go home. So, and these are things that play a significant role. And I can tell you one aspect of it, we like to use the phrase, children are not small adults. So when it comes to pediatric imaging, most pediatric clinicians and caretakers and specialists, they want the films read by a pediatric radiologist because there's a very specific training that we go through to recognize certain patterns. And quite frankly, general adult radiologists aren't familiar with all of them.
Yeah, absolutely. Particularly, right, pediatric elbow fractures are particularly problematic. So one of the things that I envision in the future with ortho now is, depending on the ortho now, what orthopedists are covering them and looking at those films on our app, we would have a relationship with your pediatric teleradiology company for those particular cases where it's pretty subtle. That treating clinician would be able to make a disposition whether just an ACE wrap versus a long arm cast versus calling in one of the elbow or pediatric or orthopedic specialists and may need pinning. So those are important decisions. So I think that what you're doing is groundbreaking, and
Thank you.
I'd like to get into now the way this affects our healthcare system. You brought up a number of points, and what we do every week is we ask our guests to give us three salient points that could really improve U.S. healthcare. Just three, bang bang.
Absolutely. So I recently got a Texas license. Pediatric Teleradiology Partners has a client there in the Houston area, urgent care client with multiple centers. Texas has done something very, very, very important. They have a law that prohibits the corporate practice of medicine.
Right.
Now they've also done tort reform, which we've done in Florida to some degree, but I think that is a very key point to help empower independent physicians to get back into the fold and be able to treat patients the way that they see fit. Over 80%, maybe higher, of doctors are employed, and that's not a good thing for medicine. So that's number one.
Right. So you're saying that those states do not have corporate practice of medicine laws, right? I mean, in other words, physicians are allowed to have a business, correct?
Right. Yeah. I think if you have some laws in all states, or what I would prefer, where there is some prohibition or some control or regulation against, so private equity, for instance, just owning, 90% of, say, cardiology practices or radiology practices. That would help independent practitioners and entrepreneurs like ourselves to be empowered to do business and treat patients the way we see fit.
Yes, when Ortho Now was a franchise, I remember that was very challenging for us, and the amount of money we spent on legal, just dealing with this corporate practice of medicine laws was onerous. And I think at some point, to fix U.S. healthcare, we might have to say, okay, I very much like the states having independence. I mean, that's a federalist concept, perhaps. The reality is, with U.S. healthcare going the way it is, what you just said really needs to come down from the federal government. I don't think there should be a big difference between Oklahoma and California, right? And currently there is. So okay, so that was your first point. Second.
So the second one is, I went to FIU. I love FIU. I do a lot of engagement and speaking with the FIU Foundation and alumni regarding diversity. And specifically when it comes to medicine, FIU is one of the top producers of minority students, being mostly Latinx students, and they've done a great job with others as well, minorities, African Americans, so on and so forth. But still, as an African American, I can tell you, you're talking about maybe 3% from between 2014 and 2021, 22 of Black males matriculating to medical school. So you're talking about an uptick of 0.6% in 8 years. That's really not a good, barometer. So I think we can do a lot more to increase diversity in medicine across the board. And I think that will be good for patient care, because patients tend to do better when they're seeing people who they feel they identify with. And again, that's just one of the things that I think we can do. And I think they're doing a magnificent job at it at FIU.
Well, I think the timing is right in our society. I think people realize this, whether it be law enforcement or legal work. When people understand culturally the group that they identify with, and in medicine, they're going to have better outcomes, right? They're going to listen to that doctor more to make sure they take their diabetes medications, right? I had this discussion with Dr. Michael Galvez. I don't know if you've met him, but he is a pediatric hand surgeon, like me, in California, and he tells me that only 6% of physicians in California are Latino, but that's a very Latino state. Of 40% is 40% is Latino in the state of California. So I think you hit upon something very important here, and we have to just keep working on exposing young people to medicine and giving them the opportunities. And I always say the opportunities, not the handouts, right? People need to work for it, but you got to expose them to it and help them in the process. So I think that's a great point. So third point.
So I hate to kind of sound cliche, but I definitely think they have to address Medicare. I guess Medicare, although great concept, probably has some unintended consequences. When you have these arbitrary fee schedules and cuts because the budgetary concerns of Medicare are there, it's not good for practitioners and people like ourselves. There's some rationale, but really in some cases there isn't rationale where you're cutting reimbursements to physicians. However, the majority of spending in healthcare really goes toward administrative costs and insurance. So I think a lot of people are not aware of that. They think, oh, these doctors are getting all this money, but that's not really the case. So I think some addressing Medicare in some form or fashion, I think there's other ways that we can reduce costs. I think we can have different rules and laws, which probably have to come from the government, where maybe, we can do altruistic acts and do pro bono type of work with medicine and donating our time and care. I know you're doing some of those things, but I think there's many different ways other than, how we're doing it currently.
Yeah, they're trying to cut costs by cutting the people who actually are providing the care and have been cut repeatedly. I was speaking with an ophthalmologist who told me they used to make about $1,500 to do a cataract, and now it's about $500. That really doesn't cover your. And the public needs to understand this. I mean, look, any one of us any day in a week would take $500, right? I mean, $500, $500, you can do some. But when you have this many employees, right, a facility, malpractice premiums, and everything else that goes into practice, it barely covers. Well, in many cases, it does not cover the cost, and that's why many physicians are retiring early. So this is you brought up something that is going to be a crisis. Okay, I supported at one point Vern Buchanan, who's in your area. Actually, he's a congressman from Florida. He is set to be at some point the next chairman of the House Ways and Means Committee. Well, the House Ways and Means Committee basically regulates CMS spending, that is Medicare. So I think it's not increasing spending; it's spending it in a smarter fashion, and that's what I've always said is that we have to just redistribute how those healthcare dollars are going. So those are 3 great points. I'm going to give my weekly. I give my 3, and hopefully some people give me some pushback because I want to see some dialogue and some argument here. The first one is see the right clinician at the right time. If you see the right type, and it doesn't have to be physician. It might be a nurse practitioner. It might be an orthopedic PA. If you see that person at the time that you need it, chances are there'll be a lot less healthcare spend because you're not now referring to multiple people. And this is why the gatekeeper concept is antiquated. All right. Our primary care colleagues need to be keeping us healthy, need to be treating a chronic disease, following us yearly physicals. All right. Really detailed, not giving, an authorization for somebody to see me for a pinched median nerve, carpal tunnel, syndrome, or that ophthalmologist that I mentioned, right? When a patient has needs a cataract, you don't need to go to your primary doctor.
Right.
I mean, so let's rearrange the system. The other thing is that ties into that is we need oversight, not authorization. All right. In my book, I mentioned that authorization is a 4-letter word. Okay. All physicians hate it. Patients hate it. It makes no sense. Once somebody comes to see me or somebody like yourself to read a film or that ophthalmologist, that should be the authorization. Now, there are bad apples, there are people who overutilize, so we need to be, there needs to be oversight, and I have no problem with that. And the last one is what we're doing here, right, Dr. Crapp, public education. The big challenge is how many people listening in are non-clinicians, and that's the challenge we have is how can we get people as interested in this as, say, Kanye, right? I mean, like, come on, our society needs to say, you know what? There's stuff that's fun, but then there's stuff that like this that affects your life and your family's life. So the question is, when will popular media finally, speak to people like us in the trenches and try to understand why U.S. healthcare is now 20% of our gross domestic product, twice as expensive as the next country aligned, which I believe is Switzerland. So these are really real issues. So I'm going to give you the last word, Dr. Crapp.
Well, thank you so much. It's been a pleasure, and it's always great to converse with you, and hopefully we'll do it real soon in person. But I just wanted to say, in thinking about all of this, for the public, I really want them to understand that, physicians, our mantra in the Hippocratic Oath is first do no harm. So it's, we're not the pariahs, we're not, the greedy people. In terms of looking at certain laws and regulations and things, when you look at it in the public sphere and on the news, it's really a situation where we're trying to create an environment where we're able to be empowered to do the best thing we can do for our patients. And it's called the practice of medicine, not the business of medicine, even though if you don't know the business of medicine, you may be out of the practice of medicine. So absolutely. Eliminate the hurdles.
Thank you so much, Dr. Crapp, and I look forward to working with you to disrupt it on that business side.
Thanks so much, my friend.
Thank you, everyone.
Thank you.
You can listen to this in its entirety later in the day. Okay. Bye bye.